problem, no problem. One of the things that, for those of you that don't know me, I'm Charlie Twig. I'm the chairman of our Community Advisory Council, or CHIP group. I want to welcome all of you. Everyone keeps thinking we have lots and lots of conference rooms, and there's no shortage of conference rooms.
Oh, yeah.
Well, pardon me?
Oh, yeah. There is a shortage of conference rooms at home.
When we built this hospital, and this room wasn't really planning on being a conference room. It was going to be something different. We said, oh, we won't have a meeting. Well, we don't have anywhere near enough conference rooms. We're constantly using it. And so as an example, we had a class here just before at CC. You were involved. I don't know if anybody
Yes.
else was.
Sherry and Diane.
Great.
And I booked that conference room in November. I booked this room for that class. But they had the kitchen right before us and you right after us. So it was like back to back.
Sorry about being a little late. Remember, we used to have our meetings at 5:30. So when we changed, that's what caused us to have a little bit different time. So sorry about the delay. I know everybody's time is valuable, so we'll want to get into this as quickly as we can. We're sending around a sign-in sheet, so if you would sign in. And
We did that. It's
you
going
already
to
did it? It's on its way around? Perfect. So let's start off by, as we've been signing in, let's introduce ourselves. Cece, can we start with you?
I'm Cece, or Cecilia Montgomery, and I'm on the board of the Senior Center. And I'm also with the auxiliary. Vicki Taylor, Head Start.
Jamie Davis, OSU Extension Service.
Amy Harcourt, the Rare AmeriCorps member at the hospital.
Paul McGinnis, Greater Oregon Behavioral Health and the Eastern Oregon Coordinated Care Organization.
Amanda O'Brien, I'm the volunteer school garden coordinator for Union and the farmers market manager for Saturday Market.
Tara Richter, I'm the outreach coordinator for Health Integrated, which is the contractor for the EOCC, or Personal Health Management Program.
Mindy Bentley, Regional Community Outreach Dentist for Advantage Dental.
We need a
Oh, sorry.
Go ahead.
Oh, Mindy Bentley with Advantage Dental.
Thank you. Rachel Klippenstein, Westside Region.
Shane Morgan, Lakeview Gardens, and Senior Center board member.
Jimmy, you want to introduce yourself?
Jimmy Hall, Lake County Examiner.
Thank you. And those of you that don't know us, this is Mira Norris, and as I said, Charlie Twig. So welcome. We have some snacks here. If you'd like to help yourself, please do. Did everybody get a copy of the minutes we sent out?
Do you need one? I have one. Share.
I just printed out some in case somebody didn't have them, but otherwise.
Oh, it wouldn't print when I did it.
Well, I did that on purpose. We wanted to make sure it was really difficult for everybody.
Really?
Well, we're trying to cut down on the paper.
Yeah, that's why you got computers.
Yeah, that's right. So every time we print a bunch, people say, oh, I read it on my computer, and then we don't print it, and people say, oh, I didn't print it. Anyway.
Sorry.
I would like to ask if there are any corrections to the minutes, or that reflect kind of what I'm talking about. If there are no corrections, could I have a motion to approve the minutes? Cece, you have a question?
No, I move that we approve the minutes as written.
Great. Do we have a second?
A second.
So it's been moved in second. All in favor to approve the minutes? All in favor signify by saying aye.
Aye.
Any opposed? Same sign. Thank you. Those have been approved. So Mira is now going to do a recap of our, actually, before I go any further, I should ask if there's any changes to our agenda. Everybody has a copy of our agenda, I hope?
I don't.
You have a copy? Here's a copy.
I'll grab them. Thank you.
You bet. You bet. Do we have any changes that we'd like to make to the agenda? Hearing none, do we have any announcements? Anyone have? Jamie?
Sure. So Mira and I are working on a youth advocate for health program, and we're working to train older youth, so who will be juniors and seniors in high school next year, to deliver 4 health-related lessons in school next year, both in Lakeview and in North Lake. And I have job descriptions for our teams and applications. I'll pass these around. If you would like one of those. And if anybody knows of a teen who would be someone that you think would do a really great job in this position, Mira secured a grant that will pay them a stipend as well. But this is great for people who are interested in maybe pursuing a healthcare profession or being a teacher as well, delivering education in classrooms. So we're really excited to get started this fall and evaluate the program and have more for you, or more to share with you on our results later this year.
Awesome. That's fabulous. I think it's really important that everyone keep in mind that all these activities, not only are they important, but they do cost money. And getting grants is really a big, important part of what we're about trying to do, so that we can continue this process and keep working on improving the health of our community. So this is really a good thing that you guys are working on. So thank you.
Thanks, Jen.
Any other announcements? If not, Mira, would you like to talk about the oral health conference that you attended?
Sure. Actually, Mindy and I will be discussing that. So last week, Mindy and I went to the oral health conference that was put on by the Oregon Community Foundation and the Oregon Health Authority. And we met with many different communities that were implementing school-based oral health programs. And we heard what they were doing, the progress that they were making, the challenges that they went through. And we also learned that there is some new Senate bills that passed. And those Senate bills require schools to now have children that are under the age of 7 be screened to register. So that's something that Mindy and I have been working on with the schools. And the other part of the bill is that we have to conduct services during school hours. So we're ironing out the details of the school, but until then, we're working hard on trying to educate the community on why it's important. And Linda Saxton, the director of the Oregon Health Authority, I got to sit with her and kind of just vibe out on her thoughts on our community. And she was really excited about all the work that we're doing in little Lakeview County, and she actually was like, I'm gonna come visit. So she, in her speech, pointed out that Lakeview County is one of the worst in the state in terms of cavities. So it's on their priority list. It's on, the state has their eye on Lake County to focus on this area, and I believe it is something really important that we need to prioritize. Did you want to say anything?
I'm just excited, anxious to get things going here. I also do the same type of work in Crick County, and we have a really successful program there of offering these services there. The school loves it that we come in and do this. The parents love it that we come in and do this. Offering the services during school and at school really is a benefit to the parents as well as the students. They're limited time out of class. Parents don't have to come get them to take them to the appointment, set an appointment. Services are free for all students, not just OHP, anything like that. So it's a great service, and I'm really excited to get going in Lake County.
And we really appreciate everything that Advantage Medical has been doing to volunteer and take the time. Mindy drives out here every time, multiple times per month, so we appreciate it.
Question on the meeting. I know that John Adams, who's the director of the Eastern Oregon Healthy Living Alliance, was there as well, and they've gotten the grant from the coalition to do school-based programs. How well are we connecting?
How well are we connecting with EOLA?
Yeah.
Well, we saw that EOLA has its focus areas on counties that had not established programs yet.
Oh, okay.
So, and as you know, I'm the board of directors for EOLA, so I'm definitely in the loop about that. John was with us the whole time. They gave us the data on how well we're doing, and It wasn't as great as we had hoped, but I think that's similar to across the board with other
Who's the
counties.
they that gave you the data? The Oregon Health Authority?
It was the Oregon Health Authority.
So that was the data that wasn't necessarily matched up with Advantage Dental screening data, correct?
We provided the data. They get data from all the different grantees, and Advantage provided our data.
Oh,
So trust
okay.
me, yeah.
Yeah, so it was more accurate than the OHA's data where they were
Yes.
conducting the screening?
Yes, yes.
Okay,
Yes, because before it used to be OHA and they would not share that data back and
Right.
forth and whatnot. This data came from Advantage, what we provided.
okay. And do you remember what our carries rate was here in Lake County?
They were still mentioning the 73% rate.
73% of all mouths have caries.
Yes, and they were actually only focused, if I'm not mistaken, Mindy, on second graders and sixth graders.
Third, isn't it third?
Yes, it
But-
wasn't all across the board.
Right, they do the screening on a certain group of
Correct,
kids,
yeah.
but
So I did bring that report that
Great.
I had, so I'm gonna pass it around, John, you probably find it very interesting. So, their report is only for first, second, sixth, and seventh graders.
okay.
Is that a public document? Can we get a copy of that?
I believe so.
Yeah, we can just copy it, scan it out to
Yeah, we didn't have any data really for updating the assessment
Right.
until I heard this, so.
That might be something that we could share with the public, to let them know how we are doing and why the activities that we're doing are really having an impact. That would be, I think, would be really helpful for people to know how we compare and the impact that these sealant programs are having on our population.
Okay. Is there any questions about that or thoughts?
Just out of curiosity, because you talked about the Senate bill and required for 7 and under 7. So does that mean, I think we had talked before about some people wanted an opt-in versus an opt-out option. So does that mean that is off the table? You will be your child will be having it, which, I think is fine. They need to have it done.
No, it's not. So parents have the option to opt out. Advantage Dental worked to make a new consent form that would provide opt-in for any sealants or varnishing. The screenings are what is required. However, still, if a parent wants to opt out, they can do that similar to immunization.
Because that screening can be provided by their own dentist, it's not like it has to be provided by the school. We're just obviously offering a huge service by allowing it at the school.
It makes sense to have it, but you always have somebody who does not like it.
I must be reading this chart wrong, or it doesn't have data, because it says 0% had needs.
That's Mira,
Yes.
so this is quarter,
But this other data is important in terms of where it talks about the results of the screening and the need for care. About 10% of all first and second graders had an early need for care, which meant they were referred. 0 had emergency, so that meant, exact terms, I mean like infection, basically.
An urgent need, yes.
Right, that means you'll get into an Advantage dentist
Within 20, or any dentist, but definitely
within 24
to 48
yeah,
hours.
and get served. So 10% of first and second graders, 17% of sixth and seventh graders. And I'll keep shooting this around, but it basically said on decay there was 0% in both groups, so I don't know.
There's more information, yeah, than what is just on here, obviously, sorry, I didn't read through that
Okay.
whole thing. Mayor, are we able, excuse me, basically to request the full, kind of like a snapshot, but of everything? Do you know if that's something you're requesting from Molly?
I can certainly request it. I don't know what they'll say, but absolutely can try.
And up at the top, Charlie, it says preliminary results. So I'm not sure if they were just releasing that to conference participants or whether it really is for public consumption.
So how can we find that out?
I don't know, I guess we're gonna write to the Oregon Children's Dental Health Initiative and get the other county reports that look like this, is what I'm gonna do, so
Okay,
I'll find out.
I don't want to give anybody wrong information, but I think
Right.
the more that we advise the public of how we do, how we compare with others, I think that is helpful.
Well, and I would think that they would be able to provide, at least with their firm with the grantees, the comparisons there.
Okay.
Is there any other questions? Okay. We're ready to move on to explaining consent of dollars.
Paul, would you like to talk about incentive dollars?
Please.
CCO.
It's, at our last meeting, we used audience participation tools to answer some questions about how we felt that LCAC was doing. You know, do we have goals? Yes, it was a strong response. Are we meeting the triple aim? Maybe. That's a big question in terms of achieving the vision. But one of the questions asked, I have a good understanding of incentive measures and how LCAC funding is tied to these measures. And we had a 53% response rate from the group of people that were here that said that's a false statement. And correlating to the priority setting at the end of the areas where we had the issues that were identified for moving into the next agenda item, the incentive measures were, I believe, not last, but next to last in terms of the priorities, with health disparities being the lowest priority. And so I think it's important, we did this at the Harney meeting, and people seem to appreciate the brief educational session, and that's what I'm going to do here right now. Is here's how it works. The Oregon Health Authority is in partnership with the federal government for the Medicaid program. They asked for a waiver to operate the Medicaid program in a different manner, called coordinated care organizations. They established 16 of them around the state. Lake is part of the Eastern Oregon Coordinated Care Organization. Each of the coordinated care organization gets what's called a global budget. It means they give the money to that organization, not based on claims and all that, but based on how many people are participating in the program, based on the eligibility categories that they may be part of, the Affordable Care Act population, TANF population, the adults with disabilities, the folks that are Medicare and Medicaid qualified. It all comes, it's just one big chunk of money that comes to each of the CCOs. But before they send that money to the CCOs, they say essentially, we don't want the coordinated care organizations to behave like a private insurance company would have in the past. If we were the Lake Health Insurance Company and we were in the for-profit insurance market, or even if we were, you know, a non-profit like Blue Cross Blue Shield, what we would do is we'd collect up premiums from everybody, right? And we'd have a nice stack of money, and we'd have a little bit of reserves, and we would pay claims as they came in. We would just, you know, we'd qualify somebody who went to the doctor, and we would pay the doctor, and that's how the system would work. There was no real incentive for insurance companies before the Affordable Care Act to emphasize prevention and health promotion. So what happened was the Oregon Health Authority withholds a certain percentage of funds from that global budget from all of the CCOs. This year, I believe it was 3.6%, which would be equivalent of about $10 million. That percentage increases each year. And then they gave us 17 incentive measures in which we were supposed to perform, and if we do perform, we get that money back as part of the incentive measure withhold. If you look at what the incentive measures were, when we showed you how Lake was doing in those areas from the presentation, you would notice that they're all about prevention and promotion. They're about early screening for kids 0 to 36 months. They're about adolescent well care visits. They're about colon cancer screening. They're about controlling diabetes, hemoglobin A1C levels. They're about controlling high blood pressure. It's stuff that, you know, is part of the preventive service mix that we really should be delivering to people. So if we get these dollars back, that's how the money is redistributed to the LCACs based on population. So if you remember in 2013, the percentage withheld from us and what we got back, you guys got $3,125. Last year, the percentage grew, and I believe you guys got 28,000 or something like that, based on the number of Medicaid recipients. This year, if we achieve the measures and it's close, we're not necessarily going to get all of that 10.6 million back this year because we haven't met several of them. It will still be more than it was last year. So you're likely to get more resources just as that percentage increases for the local community advisory council to try to impact those incentive measures that are about prevention and promotion.
And that money comes back to Lake County directly?
No, it comes back to the CCO.
Okay,
Because,
so the Eastern Oregon CCO?
Yes.
Get it for our area, for our region?
Yes.
And then who administers that?
Who administers?
The amount of money that we get back in?
Oh, the board of directors,
Of that EOLA or?
EOCCO,
The EOCCO board of
Yes.
directors?
determines what they're going to do with that. But a percentage is set aside to be redistributed to the LCACs. The largest percentage, I believe, is to pay for patient-centered primary care home clinics that reach a tier 3. So they get $15 per member per month.
So one of the things that happens is the way the financing works is, as Paul said, there's more and more incentive dollars. But that means there's less money to pay claims. So what the CCO board does, and I'm fortunate to be able to go to those board meetings to have our voice heard, is I want to say, we want to have the money to go pay for the doctors to deliver the care, or the hospitals to deliver the care. But we also want to have money available for, like, the efforts that we're coordinating to have people do things that we normally wouldn't do with claims. As Paul said, prevention is not a normal thing that hospitals get involved in. We are in the business of taking care of people before they get sick. We only take care of them after they get sick. So we're trying to change the incentives, and that's what these dollars are all about, to make sure that that money, or some monies, can be used for what we're trying to do here. So then what the board will do is say, set aside some money to pay for the future, because nobody knows how long this funding is going to last. And some to pay for the incentives, because we want to have doctors encouraged to deliver more care to patients. And then we have some monies set aside for prevention, and a lot of what we're doing is prevention. Some of that monies come to our group. Some of it goes to the doctor groups to say, you want to do more prevention. Because remember, just because we encourage patients to go get their colorectal screening, we still have to have the doctors deliver that care, nurse practitioners deliver that care. So we got to do both. And I don't know, I think we have talked about in past meetings how those dollars get split out. As soon as we have that information, we'll probably find out next month. Number one, if we got any of the money, or how much. And then number two, how that money is gonna be spent. And I'm happy to share it. Yes, ma'am.
So do you meet with the doctors and tell them this is available, we're searching for money for them? No, and are they appreciative of it, or don't care, or?
Well, it's a combination of answers. First off, physicians care about your health, but they can't care, when you go to see your doctor, does he talk to, or she talk to you about how much you eat, how little you eat, how you exercise? Hopefully they're doing those kind of prevention, telling you not to smoke, those kind of things. What we want to do is give them incentives to push you a little bit. We also want to figure out ways to approach you as an individual, not you as a person, but all sorts of people within our community, to give them incentives to want to do the right thing, or go see their doctor every check.
But we just had that meeting to understand why the colonoscopies didn't match up to the number of people that we thought.
That's because people don't want to have that procedure done. I mean, you know, how many people line up and say, please,
But it was, apparently it was one of the worst records of all the Eastern Oregon counties now, and we were trying to decide what possibly could that be.
Because it's 55 and older, and that part of your body is your part of your body, and they don't want any foreign matter or et cetera going to that area.
You know what? It's a tough, touchy subject to everybody. So.
But
if
we got over the breast cancer, we weren't allowed to talk about that 20 years ago. You know, what? You know, now.
You're right.
We need to.
And you know what made breast cancer become such a really good issue that people could talk about? Women. Women allowed us as a public, as the population to talk about it. That's a really important thing. How do we get?
Yeah, we did conduct those 5 focus groups in the 5 counties that were trying to do something around colorectal cancer screening, Charlie, and one of the points that came out from all of them was that we need more testimonials from people in the communities that people know.
Yeah.
And that's already been a proven value in terms of getting other people screened. So, I mean, people can talk about breast cancer because, again, it's accepted. Whereas for colon cancer screening, we're still trying to break that barrier, and that's called community norming, where it's normal to, you know, get screened rather than it being something under the table. And in fact, that's one of the goals in your plan too, about the depression and people getting help.
And I wonder if some of this that you're speaking about getting the word out could happen through the NONUS committee with the patients. And NONI, is that her name?
The patient advisory committee, or
Yeah.
council, or whatever you call it.
No. Yeah, I mean, there's all different kinds of ways. We gotta just keep the conversation going. And a lot of what we are asking you to help us with, that we all do, is to how do we communicate to people? How do we get people to do the things that we know are right, when oftentimes they don't? So, sorry, Paul, I didn't mean to take any.
No, that was, you know, I just wanted to make sure that you all understood how that process works. And your question, though, from public health was, you know, does it come back directly back to Lake? And the answer is EOCCO gets measured by all 12 counties. And as Charlie has said it a couple of times, if Umatilla County and Malheur County don't meet the incentive measures, it just doesn't do well for our whole region, because they just have so many more people that are members of the play. What we're trying to do, and Ken, you know, we've talked with Ken and others, you know, we do need to figure out a way to actually, we give $15 per member per month to every clinic that's a tier 3 primary care clinic. But there's nothing in that contract that says you have to meet the incentive measures. And we need to emphasize the clinicians that are doing the job better, and reward them better, and we need to recognize and create a method that says, you know, despite how small they are, Wheeler County does really well on this stuff, you know, and they got a significantly less amount of money than you guys did because there's only 300 plan members there. So you follow what I'm saying in terms of trying to make that change to recognize what you're saying, and make that, those resources be able to come back for places that are improving.
One of the things I think that fit to your question, that a lot of the counties are saying, is how do we get more money into our public health? Because that's where a lot of things can be done.
Oh, that wasn't my question, I just wanted to understand when you say that comes back, like, to this group, like, who, or whoever it comes back to, where exactly does it come back to, and who's administering it, and who's making the decision on how it's gonna be spent?
This group made the decisions. Mira put the applications together. We get a third party, we being the EOCCO, gets a third party, the Oregon Health Sciences University, to look at the applications and say, what they say they're asking to do makes sense. They have a decent evaluation plan, and it targets one of the, 18 incentive measures that we're trying to impact.
So for example, for Lake County, the monies from last year that we got have gone for the Go Girls program, have gone toward sort of powering younger people.
This one?
This program, and those are things that we've talked about here at this meeting. And where the money comes is the CCO sends the money, the hospital gets it, puts it into a set pool to be used as this committee or this organization says. And then that's how we spend the money. So that's how we do it.
And the next
So like for
round, we
incentives
have,
for positions or whatever, that's okay through this committee also, like?
No.
No.
Okay.
And that's
That's a board level decision.
That's the board level that
And so-
decides so much goes back to the positions or.
And so part of the goal that the board has, overseeing the CCO, which is very much like an insurance company, is we have lots of experts like Paul and others that understand a lot about the healthcare business of healthcare. How do we manage populations? And how do we incentivize physicians to do things? Then we ask physicians, what would they treat as an incentive to do something? So, I mean, it's a very complicated process. But you have a lot of people ask.
so in terms of the incentive measures and the money that we receive, the next round, now we can all be prepared with ideas to come to the table. When that money comes, when that grant opens up, we will meet as a group and put our minds together to address the priorities that we have set through that funding. And like Charlie said, the Women's Health Ambassador and the 2 other programs with youth and health was how we used it this time. We can come up with something else and a different kind of innovation as long as it's feasible and it addresses our priorities.
And the money is geared toward those 17 incentive measures.
So you pick which of those incentive measures you wanna focus on. And then you apply for a grant to get the incentive measure money and work on those projects. And then at the end of the year, if you haven't met those incentive measures, you don't pay the money back.
No.
Okay.
It's a grant, so we
It's
get
a
the
grant.
money.
So you get the money to do the project, but you don't pay it back. So right now, we're looking at incentive measures for next year. And so it's like July to July, is that when it runs, or roughly?
We still don't know if we met the calendar year 2015 measures.
But if we didn't, it shouldn't affect this next one, correct?
No,
Or-
which next one?
Well,
If, when 20,
So you
when
said that it's
2015,
grand.
when 2015's over, the money that Mira and this group has had was for 2014. So these programs that Charlie mentioned was from the 2014 incentive measure,
part of the reason.
Soon though, I mean, Charlie's right, by the end of June, we'll know what we're gonna do with that money. The board will decide that.
But the projects will be done in 2016.
Yes.
That we do with that incentive measure.
Or 2017,
So you're-
really, I mean,
Yeah, okay.
there's this big lag,
Yeah, I see that.
you know, as the data is collected and the state verifies that we did or we didn't.
One of the reasons why there's a delay in how we measure, how the state measures this, because frankly, that's who's deciding this, is the state, is by claims. And claims are when, if a doctor sees a patient and bills for that service, that's how the state knows that service was delivered. Okay? So what we want to do in meeting our incentive measures, like take the colorectal screening. We told everybody you ought to have it done. But if they don't actually go in to their doctor or nurse practitioner or PA, have that procedure done, and then have that doctor or nurse practitioner or PA bill for it, the state says it wasn't done. So there's a delay of about 90 days from when a service is delivered until the claim is actually paid. So the computers it takes that long, you know, the doctor's office may not bill today for services that were delivered today. It may be next week. That takes a while to get claims paid and all that. That's why even though we are in May.
March 31st was the cutoff.
March 31st was
claims.
the cutoff for all claims. When they have to process the data, we tell them what we had, they come back and say you met the measure based on that information. We squabble, the CCO squabbles, and then they come up with the result. And that's all, so here we are in May, and we have to meet 2016 incentives, and we don't even know how we did in 2015.
Not only that, Charlie, we don't know what our benchmark is for 2016 yet. We haven't been given that yet.
And it's gonna be
And
higher.
the bar keeps rising, right?
So the game is stacked against us, which means we gotta keep moving faster and think smarter.
And also strategically, I think, you know, anyone that's involved in public health knows that population health, it's not a quick turnaround for people to understand, you know, the reasons why they need to take care of themselves. So, for example, us investing in our youth or investing in having women disseminate information, like the Women's Health Ambassador, that might have slower effects, but it's impactful in the community on the long run, and in many other arenas that might not hit the incentive measures right away. So yes, I want to keep us on time, but we have to think strategically, be prepared for the next round as leaders, and you know, we come up with these conclusions together as a group.
Oh, keep taking away your
Yeah.
time.
No, I was done. I mean, people need to understand this, that's why with 53%, and it wasn't any different in Harney, it was a little bit better, but, you know, people had similar questions. How does this really work? And, you know, so it was important to spend that time, I think. But it leads to, go ahead.
Go ahead.
Well, I was gonna move our agenda. Do you have a question on the incentives?
Yeah.
Go ahead.
I just don't understand, if a doctor tells you need to have a colonoscopy, by golly, you go to the doctor. But if we tell them you really need to have a colonoscopy, they're like, forget it, you don't know what you're talking about. So what if we talk about incentives about breast cancer, because women talk about it, then maybe we need to get a medical clinic meeting with the various people, doctors, nurses, PI, in a room, big room, and then people like me can say, I had lung cancer, and this is what I did, and this is what the hospital did for me. You know, you could combine both of those, and if you had the doctor there as well, or the nurse, whatever, medical person, that, to me, would really impress people.
So you're absolutely right. Those are really impressive things. The bigger problem we have is the people that don't go to the doctor. So it's not so much the people that do, but there's a whole lot of people that just don't go. And they don't go for lots of reasons. They don't feel better. they don't know that they could feel, this is preventive, they're not sick right now. This is preparation so they won't get sick. So some don't go, some are told but don't get around to it. Some are afraid of going. They want to find out. Yeah, I've been smoking for a long time. Yeah, I'm probably gonna find out something bad. I don't want to hear it.
We heard that a lot in the focus groups too, about reasons for not screening. I just don't want to know.
Some people just, so,
I just guess we should put together a little newspaper that we could mail to each house, like an advertising thing. And when we were looking at the various things that
Materials.
the counties did, and actually Lakeview had a pretty good one-pager. And maybe that's something we should get together at another time or something, and then we could have a picture of me. She had lung cancer, and you can do it like a little thing, come listen to her on so-and-so. Her husband just had a colonoscopy. He found out he's over 73, and they say they don't want to do it. So you can give them more information, maybe. I don't know, just think. I get irritated with people that just don't bother coming to me.
Welcome to the world of dentistry, huh?
imagine how you are, if you're a dentist, all you can do is, essentially, all you can do is fix people's problems that they've been not doing for years.
Yeah, but they have done a better job of that now. I mean, my mother, dad had false teeth. I don't have false teeth, so obviously they're doing a better job of it. Well,
You
so
did
we
better
need
than
to.
your teeth. That's great. You did better than,
Yeah, well,
flossing.
but
Don't you
they
remember?
people made me aware of
Sure.
what I could do with my teeth. We need to say, okay, poop is good, or something like that, get their attention, or.
We need something like flossing. You know what's that saying? You only floss in the teeth?
When we're mixing floss and colorectal cancer screening, that's
You only have the teeth you want to keep.
That's it. And if we could have something like that for so many of those other things, yeah, only floss the teeth you want to keep. Those that you don't,
That idea.
well,
I like that idea.
okay, Paul, you are moving on to the next one.
Yes.
Sorry.
So-
Right here.
So just as background again, we had talked about the need to update the community health improvement plan by the end of June. And we brought the data that updated things from 2013 to 2016, the most recent data elements. There was a nice story in the paper, thank you Jimmy, on what happened at our last meeting. And we prioritized some things at the end. We didn't talk about it, we just got numbers. And now what we want to do is make sure that we got the 4 areas that we want to have in the plan. 2 meetings ago, we had an update on what was happening in all of the activities that were in the plan. Mira did a nice job of putting that together. And when we did prioritize last time, this was just a numeric function. What we came up with was still physical activity and obesity. The incentive measures that could be related to that when you're trying to encourage people to eat healthier, food-wise, is you're controlling hemoglobin A1C levels in people who are not diabetic and keeping them from being diabetic, and controlling hypertension. So I mean, those are 2 things that you can directly tie the activities that you want in your plan to move that forward. The next area was senior services. This is a unique piece, really. Not that the Lake County was any different, but when Charlie opened the meeting, he said, "Welcome to the Lake Community Advisory Council meeting and Community Health Improvement Partnership." You guys serve 2 different roles here. One is the broader community. The Community Advisory Council deals with the population that I'm concerned about. Not that I'm not concerned about all people in Lake County, but that the EOCCO is concerned about, which is the Medicaid population, or about, what do we have here, about 2,000 people, 1/3 or something? Yeah, about 2,000, about 1/3 of the people are under that plan. So when you picked senior services, and in the last area, you got the senior navigator position that has been at this board, that grant came from a different source than EOCCO. EOCCO can't spend Medicaid dollars on Medicare recipients. if that makes sense. I see some heads nodding. You know, so you have to go to different sources for that. But we did prioritize senior services again. That's fine to keep in your plan. There aren't many incentive measures that fit there for that population, except for, again, hypertension, diabetes, and proportion of the population between 65 and 75, that's for colon cancer screening. The third area that came out was mental health services. It was also in your last plan. In that area, we have screening for depression, any chronic illness. If people have been diagnosed with a chronic illness, about half of them have depression as well. So we could go there. And then the fourth area was early childhood, which was something new for, was not in the plan before, but we did have the creation of the early learning hubs and the focus on kids. But in that area, what we're really trying to do is the developmental screens for kids 0 to 36 months. And it's to get them a good start. There are community wraparound services that serve those families. If we identify people who really need some help, you know, the work on brain trauma and what happens to kids later in life if they've experienced abuse, neglect, trauma, those kinds of things are all part of children's and mental health as you want to go from there. So we don't have to, you know, change any of that, but I wanted to make sure we had a discussion so that Mira can go back, look at the lake plan, you know, see that the goals are still relevant, because they're gonna be, because we're just updating them really for the most part, but looking at some of the activities that we might want to change that better target the incentive measures, because the applications for the incentive measures say, is it in your CHIP plan? Your community health improvement plan, not the community health improvement partnership, which may be why we're trying to rename the group too, with all the changes in that. But, you know, so that you can point in, we prioritize this as a group. This is what we said we wanted to do. It makes it easier for the application process as well. So, is there, people want to talk about any of the areas that were prioritized high or some that did not reach very well? Incentive measure performance, social determinants of health, oral health dropped down to 5%. And that's the one area on the plan that was very low compared to what we had been going down there. I'm not sure why that happened. And the other one was health disparities in cancer. But I mean, it was pretty clear. If you looked at the bar graph when Mira sent that out, I mean, those four jumped out. They were clearly, you know, a priority among people. Charlie, please.
It would be my guess that dental dropped down because of the sense that we're already
Doing something
about it.
Yeah.
That would be my guess.
I agree.
And that is, you know, we have a good trajectory. We're not going to lose focus. But there are some other areas that we ought to bubble up to the top. And that was the only reason. I don't know if anybody else had any other opinions. Jamie, you were nodding.
Yeah, I think so too. I wasn't part of this process, but I would agree because dental seems to be something that we keep hearing and getting frequent updates on. That's one prioritizing looks like something we put a lot of effort towards and have movement on. Sustainable movement with advantage, so.
And so the definition for early childhood is till 36 months? Is
0
that
to 6,
Zero to-
actually.
0 to 6,
Yeah,
okay.
and help me with the exact wording about stable, secure homes.
Secure homes, yeah. Well,
I'm
what we were
sorry to put it on the spot there, but-
focusing on was the screenings, because a lot of agencies screen them, but they're not documented anywhere. That was a big one, and dental, because we were working with schools, but kids, 3, 4, and 5 have bad teeth already, and they're having physical issues because of that.
Right.
So that's why we focused on those big areas.
The other area that the early learning childhood crosses over with the CCO is percentage of kids 0 to 6 who go to a physician that is part of a patient-centered primary care home. And right now, the clinics in Lakeview area are working to become patient-centered primary care homes. North Lake Clinic is one. So the kids up there that go there, we get that as a percentage. But those are the two that intersect between CCOs and early learning hubs.
Right. And the stable family environment.
Right, stable family environment. But basically, early childhood, let's get them ready for kindergarten. That's healthy, secure, ready learners. So if we can do that and get them all up there, we'll do real well 15 years from now.
Could part of the factor with the dental, especially in young kids, be nutrition as well?
Yes, and I disagree that all the outcry to the community that the dental situation is better now, because the families that I'm working with to try and get them, we've had them sealed last year with Public Health and Advantage Dental. They had follow-ups, they were going to make appointments at Public Health, which they didn't follow through.
No, we're doing that.
We're
following.
Yeah, some of them are, but a lot of them, it's the thing about, well, their baby teeth, and it's just, that is something that we need
But
to.
I think the population you're
work
seeing
on.
at Head Start, a lot of them do not qualify for health insurance.
Exactly.
And so when you're referring them, and they do have mom, dad teeth, they will not go spend the money.
No,
They
they
will
don't
not.
have it.
They don't have
They
it.
don't have it, and that's what I'm saying,
So,
but
and there's no,
Why aren't they eligible? I mean, we're at like 98% of Oregonians. Oh, okay.
yeah.
A lot of them are not citizens.
A lot of them, and I said this when I first started on this committee 3 years ago, it's not gonna help the population I serve, because number one, they're not documented. Number two, they don't have transportation, and when their OHP sends them out of this county, they're not gonna get their kids served.
Well, you know, Vicki,
So that, I mean, that's been happening
so
for so long,
what's
and that's
happening,
what
Vicki, is they'll
we need
come,
to
they'll
work
do their
on.
follow-ups, they'll keep coming for the varnish, but we make them the appointments, they don't go.
Yeah, that's,
Because, and but they don't wanna tell you they're not gonna go.
exactly.
They'll say, oh, yeah, we'll do that, but they're not gonna go because they don't have the money.
We've done the same thing.
Is the
Okay, yeah.
large, excuse
So,
me, is the large percentage of the patients that are non-compliant, not documented? Is that what I hear you saying?
That's my belief.
well,
The ones that are really, that need immediate care, that are really in bad shape, bombed out teeth, that are getting
Sucking
emergency
problems, yeah.
referrals, and then they don't go.
Yeah, the worst of the dental care is non-documented, but we have a lot of kids, and we've had, Mike Saban's done emergency with them for abscesses in the past. They just, to get them in, because their OHP card, you have to go out of the county, and they don't drive, so it's been an
If
issue
they have
in
an
the past.
OHP card, we give them a ride and they'll
Yeah,
go to
but
their.
that's what I'm saying, and so now, over the last couple of years, we get more, exactly, and more awareness. I think that's the piece
That's
that,
huge, because
that
especially with
we
juvenile
have to.
population, they strongly believe, not all of them, but it's a huge belief in their culture that baby teeth are disposable. For
Exactly.
like practice teeth, and so,
Yeah.
oh, it's gonna fall out anyways. Oh my God, so getting that message across that baby tooth is every bit as painful, if not more, than an adult tooth. And unfortunately, when they're that young and they have the common, bottle rot, whether it came from a bottle
Yes.
or whatever, and there's that much rot, they can't always verbalize to her, hey, my tooth hurts, can we do something about this? And then it becomes such normal to the child that they don't know, like they just know that there's pain, so you see them avoiding healthy foods, crunchy stuff,
Exactly.
carrots, vegetables,
Yeah.
whatever.
we
So
have to,
then
yeah.
it affects their nutrition, it's affecting their speech, it's affecting their confidence, and meanwhile, mom, oh, it's okay, they're gonna fall out.
Yeah.
So, yeah, we definitely need more education.
We need more
about their
education
families.
that there is rides, there is ways to get you to different places,
and
because I
that's what
think
Vanessa
that's
is
not,
for.
yeah.
I mean,
Oh, yeah.
when I went to her meeting, it was 20 of your members that are at Head Start, all the moms. And those moms have little babies. Okay, those babies are born in America, they can become citizens, they can
Yeah.
qualify. There might be a disconnect, and as you said, it's education. I think it can fall under early childhood if we play it, like Paul said, as oral health under
Oh,
early
absolutely,
childhood.
and
Yeah.
I'm just saying that and it is excuses, but a lot of them are, and they're the first tooth, or, I just can't get them, but some of them do care, and it is the transportation. you know, and to get out there that there is a way to get you to somewhere. I think that
And
is.
the other part of the transportation issue,
Yeah.
and I'm just gonna be blunt, that population does not plan ahead. And you have to plan ahead for the transportation, to use the transportation. And they have that population has a hard time making an appointment for 2 weeks from now, committing to a ride at a certain time. I mean, that's just a different.
I get that, I
Agreed.
said that a lot in planning, totally agree, but that's where education's gonna be huge. And while I'm all for helping people as much as you can, people have to help themselves too. I mean, you have to say, you know what, you need to make this appointment, you need to do it for you, you need to do it for your child. It needs to be made a priority, we can't just, oh, it's okay. No, you should have made that appointment and obviously do it nicely, but get the point across that that needs to be a priority in your family. That priority is that child getting the care that they need.
That was one of them. Well, Marissa, she is the ambassador, she was talking about my families. That was one of the things when we were talking about that, she said, if we're gonna go over health issues, not just with moms, can we talk about kids? Because that is just a pet peeve of hers, is the poor dental and that the baby tooth doesn't matter. And so she was, you know, she was talking about when we meet with this and stuff, can we not also bring in others to talk about? And then I said yes, and check in.
These are great issues that we need to really work on, and they're very important. I don't want to derail our meeting, so.
No, we were there. What I'm hearing though, Charlie, is that those 4 priority areas with a subset of bringing oral health in under the early childhood would be agreeable to everybody.
Yes.
What was the first one again, Paul? I'm sorry.
The first one is physical activity obesity. Second one was senior services. Third one is mental health, behind by only 1%. Those first 2 were tied at 20%, and then 15% on early childhood intervention. And then the oral would be a subset of that for, so before they get to school, and the momentum is really at the school level that's been achieved right now, and then go from there.
Paul, do we need to have a vote to agree to those?
I mean, it's up to your group.
I have one question.
Sure.
The senior services, okay, what I understand you to say is that it is important to us in Lake County, but we're probably not gonna get the money for that. Is that correct?
What you had last time for senior services had to do with the navigator and.
And that was someplace else, not,
Yes,
Yes.
that money came from the critical access hospital program at the Office of Rural Health.
So part of what you get.
And that program is about Medicare, so.
so we need to pick things that we can maybe get money for.
Yeah, you can still get, it's just not gonna come from the CCO.
Okay.
That's the important part to remember about those, is we don't have a lot of seniors that are in the CCO, mostly younger people. So as a consequence, the 3 of the goals are much more focused on the CCO population. The other one isn't, but that doesn't change our purpose here, which is to focus on the health of our community, of our county.
Right, and those prevention activities that apply to the CCO population are gonna apply to every other kid that is that same age that's got Blue Cross Blue Shield or Providence or whatever the school district or you guys, provide for insurance, Charlie, I forget what you're. So, yeah, you could take a vote if you want to, or.
Could I'd like to ask, are we ready to have a vote?
You want me to say the motion, and then somebody can say, I moved that.
Would you please?
Please. I move that the Lake Community Advisory Council prioritize physical activity focused on obesity, senior services, mental health, and early childhood interventions with a subset of oral health under early childhood as our priorities for the 2016 Community Health Improvement Plan. So if somebody wanted to say that, that's what they would say.
I know.
You said that?
I said that.
Okay.
Do we have a second?
And I'll second.
Jamie, second, thank you. It's been moved and second. Do we have any discussion?
I have a question. So, kind of
think the best way to say this. It doesn't seem super straightforward, but like food insecurity can lead to obesity.
Absolutely, there
So
could be.
could it be a subset of obesity in the same way that
Yes,
oral health is?
obesity is physical activity and nutrition,
Mhm.
both. And so food and all those things, the garden, at your school garden. Yeah, I mean, those are all things that could be listed under that.
Okay.
That is a really good point.
Yeah,
I think it would work for mental health too. because
Yes.
A lot of them are very sedentary, they have a lot of depression with it.
It's a huge part. Thank you for bringing that up. Any other questions or discussion? I'd like to call the questions, been moved in second, to have the 4 items with their subsets that Paul identified.
that CC identified.
That CC's motion described as Paul described. All in favor, please signify by saying aye.
Aye.
All opposed, the same. Motion passes. Thank you very much.
We're good, Eric, go.
Thank you, Paul.
You bet.
Thank you,
We-
Paul.
We would now like to have Mira talk about the MAP program.
Okay. So, last meeting, I shared with all of you an introduction to a process of community health assessment that is sophisticated and includes focus groups and feedback from the community. So it's not just decisions made in this room where some people can't make it and then decisions get made and we have it, right? So, so this program it has been utilized in many different communities, and I want to just give you a little bit more background on it, and actually today begin the process of collaborators signing on, and we engage in this process. So what is MAP? So MAP is a 6-step strategy. It starts with organizing, so we create committees and we involve the community to create visioning, and we come up with assessments that are not only data driven, like what Paul and the CCO provides, but also community voice. And then we narrow it down to strategic issues, and we focus on our goals and strategy with an action cycle. This can go beyond just what the CCO kind of has capsulized. This is, you know, we can focus on the seniors more. We can focus on maybe the undocumented population. And we can also look for other funding sources as collaborators. So I think that this is really important, and it can also work with what our goals are with the CCO and our CHIP strategy. But because this round with the CHIP only required us to do a data update, I think that it is important that we get the voice of the community involved. And also, it fits the requirement for the hospital assessment. It fits the requirement if they are engaging in it, public health, similarly mental health, although they're going through some transitions, often they're required to do assessments. And other agencies as well. I don't know if Head Start has to do certain kinds of assessments, but it's a good process. So why use MAP? I kind of touched on it already a little bit, but it also catches the attention of grant reviewers because we would have proven that we work together to come up with strategies that reduces duplication. So, for example, Vicki, you were talking about how a lot of agencies are doing the ASQs, right? And it's not getting captured. And there's a lot of things that are duplicated within the community, and it causes just unnecessary resources going down the drain and a lack of communication together. So grant reviewers love to see that kind of collaboration. And then lastly, how can we achieve this? So this is an easy to follow format. I sent out the link to the website. If we were to do it without guidance from the outside, I think it's absolutely feasible. However, I would advise that we seek out consultation. And I put in for our letter of intent to the Office of Rural Health to get some hours of consultation for the MAP process with an organization called the Health Resources in Action organization based in Boston. They've worked nationwide, specifically with rural communities, on achieving the MAP goals. And they would Zoom in via video conference, they would spend time with me and making sure that we're following the process in the way that we should. So that's the gist of it. I want to hear your feedback if you have any questions. I know that, you know, not everyone is here today, and I've spoken with them individually, but those of you that are here, do you have any questions?
So Mira, it's more, the math is more about the process, but the instrument or the questions that we would be looking at would be something that would be driven locally? Okay. And there would be opportunity for, let's say if there were certain issues or things that Beth wanted to look at on behalf of public health, and if we could add things together, like you're saying, we're not duplicating things, or maybe the senior center, like certain people looking for that. Okay.
Absolutely.
Would this be something that we could do across the entire county?
It has to be, I think,
Okay.
across the county.
Jamie, in terms of just thinking about it, there was in a presentation that we shared before, there's like this Venn diagram that had hospital, community health assessment, public health, the EOCCO, they all intersect, and so there's lots of room for other activities here outside of the plan that I just talked about.
And I'm familiar with the MAP process, and I support it, and I think it would be a great opportunity for all of the players at the table to have, to help see what is important, the data that they collect or the address needs.
You need a bird's eye view, it's got like, you know, the outcome. Right. This cannot act at this time because we don't know answers.
And also to hear ideas from the community, like earlier, your idea about having voices that have gone through certain health issues. I mean, those are ideas that we can implement into projects. So, any other questions or thoughts? What about public health?
Yeah, I think that process would probably look good for us. So at the end, the MAP process, then does it generate a focus that generates the focus, or is it voted on at the end?
It's voted on, that's part of the process.
At the end, but generating the focus is part of that assessment process, and that's where input comes in. I believe maybe 3 or 4 meetings ago, Mir, we were asking about that, and somebody said, you know, we need to gather a group of people with disabilities and figure out what the housing issues are around people with disabilities. I mean, I would think that that could be easily fit in there where it wouldn't necessarily fit as a, you know, a broader subject matter for people.
Correct. Okay, so are there any other questions? Because if not, I would like to pass around a sheet to officially have members from the community and leaders that are here to sign on. Okay, so I will pass it around.
So the Office of Rural Health, what grant are they offering that other people might be, not that I want them to compete with you, but I didn't know that there was a grant.
Yes, so the grant is through the Office of Rural Health, and it is to focus on addressing some of the incentive measures. We applied for part of it to go towards the MAP process, and also we collaborated with public health to address the ASQs and come up with some innovative ideas because they are conducting ASQs currently and they were not being catched.
Oh, you're talking about the technology.
Correct.
Okay,
Yeah,
I'm sorry.
okay, I was like, I thought you were just asking me about the
No.
chair with the group. Okay.
Okay, now I know where you're at.
Okay, so MAP was part of what we requested.
Will this be different than the process we did when we started the CHIP program?
Not much. Because that's old
We had small
information then,
groups and
yeah.
meetings and
And that's
committees.
5 years, right?
Close.
Yeah.
Been about 3. It's been about 3 years. Maybe 4.
Yeah.
So
And these-
what you're saying, if you're going to have a group where you're checking with disabled people with disabilities, while that's not part of the original program, it could be tucked in under senior. But give you a vehicle to get together and figure it out separately.
Maybe seniors, but we have people that are not seniors that are disabled. They might be blind,
Right.
they might have other conditions.
Yeah.
whatever.
And
Oh, I see what you're saying, couldn't put them under senior. Right.
one of the things that the hospital, for example, has done is we have a partnership for patients program that we've been working on. And we're asking people from the community to give us ideas on things that will help make it easier to use our hospital. And as an example, one thing we did is we put out the sign, at night, the electrified sign, you come in at night, and it points you where to go for the emergency room or the main part of the hospital. Because what we were finding, we know where we're going when we come in. But not everybody does. And if anybody is new to the, thank you, Jamie, anybody is new or, when people come to a hospital, a lot of times they're agitated or they're frightened or whatever. So putting up a sign, help. So, it's things that we don't even think about. And having, if this MAP program will help us find things that, say, people with disabilities say, it's really nice, but you have gravel. We have to cross over to get into the hospital or to get into the doctor's office or something. That makes it really hard for us to navigate. Would you fix that? Well, some of us may never have thought of that. And simple little things can make, some people, make their life a whole lot easier.
So it looks like we have just a few minutes, and I wanted to give time for Tara, our guest, to speak a little bit about your services.
Okay, let me hand this out, how we discussed that. We're not-
Hand it out where you want.
So I am the outreach coordinator, Trevor here, I'm the outreach coordinator for Health Integrated, which is a contractor for a program that EOCCO started back in August, it's actually July, but the very end of July. And what it is a telephonic program where our clinicians will work with members. We're really focused on Medicaid members, adult Medicaid members with a chronic condition, which is listed there. Thank you. And, oh, these are.
That was something else, eh?
So, yeah, that's part of the package, just an overview for providers. But what we are is, our clinicians are focused on working with the member telephonically. We will get a data feed. There's two ways that we get our members. One is data feed from EOCCO, which is focused on claims data mostly. And then also community health workers or RNs, your providers can refer into our program as well. And really what we're focused on is not only the counseling side of it, but to figure out where they're at and where their roadblock is. There's some type of psychosocial issue with these members that is holding them back from adhering to their provider's guidance or their provider's plan, or not taking their medications, or not checking their blood pressure, or not testing for diabetes. And so with that one-on-one contact, they actually open up. It's amazing how much they'll open up on the phone and just kind of let them know where they're at, what are their roadblocks. And a lot of times it's they don't know that they have transportation. They don't know that their insurance covers their diabetes, or covers their medications. or there's a challenge with housing, whatever it might be. So that's kind of a roadblock A, and then on their second, what we're really looking at is their preliminary goal. And it might be their secondary, but it's of course our initial focus. And so working with them to take that roadblock out, what we can also do is then educate them on why it's important to be doing what the provider's asking them to do, what is, and it has been an amazing program. We've had some huge successes throughout the 12 counties, so I cover all 12 counties. My job is, as the outreach coordinator, is to work with the clinics and the community programs. That's why I like to come into VLCACs, because I meet a lot of people all at one time. And just finding out what services are available and how I might be able to be of service, but also know when our clinicians find a member that needs to know what are the transportation, what are the housing situations and things like that in the area that I have someone to talk to as well. How can put a face to those names and things like that. So, yeah.
Where are you based out of?
I'm out of LeGrand, or out of Union actually. So I travel quite a bit. And then once a month we meet with the caseworkers at NOVAD or UCCO and review care coordination meetings where we kind of go over certain cases and kind of go back and forth with the case managers there to see what challenges we might be coming up with, or some of the things that we might be able to work with them on and things like that. So it's been a great success so far. So.
It's a moving population, but they essentially are contracted to be engaged with 700 people throughout the process. So if people drop off, new people come in.
Yeah, they can opt out at any time.
Right.
And they can opt out, opt in. There's two sides to the program too. If a lot of people may not be ready for counseling or they don't need help, quote unquote, but they might be open to education. They might say, okay, well, I don't need any help with my COPD or whatever it might be. They don't want to work with somebody on the phone, but they are open to education. They are open to learning more about their conditions or losing weight or nutrition. Then for about the 6 months, we will follow with them with just educational information and then catch back with them. Say, okay, is this a better time? Maybe there were some people not at the time that we contacted them initially. So.
Great, thank you.
Mm-hmm.
Did anyone have a question?
I do, so is this, so you have to be referred to by your practitioner then?
The nice thing is you don't. You have to be an adult EOCCO member with one of those chronic conditions.
Okay.
So usually it's going to be your nurse or a community health worker or somebody or mental health. And the nice thing about our program is even though we focus on the mental health side of it, we are always wanting them to work with a face-to-face, whether it be psychiatric or be a counselor locally. We want that one-on-one as well as what we're doing alongside them.
So at 700 people out of 40,000 members, because that's how many members we have, and she's working with 700 at a time. When we shared the cost and utilization data for North and South County, I don't remember the data specifically, but it was like 3 or 4% of the people were spending 50-something% of the money. That's who they're working with, to figure out, why this diabetic keeps showing up at the emergency room multiple times, because that's what we see in claims, and we go, hey, health integrated, see what might be able to happen.
All right, will you be able at some time to tell us, people in Lake County, not the individuals, we don't need to know the names.
As far as how many we're working with in
No,
Okay.
your successes, since you've been having such great successes elsewhere. Maybe you could help us know a little bit about the successes for Lake County.
I can look into that. It's the only ones the ones I work with are the ones that the clinician has said, okay, this person has such and such. But I can definitely look into that.
And when Tara said, talk to our clinicians, those are employees of Health Integrated.
Correct, yeah.
But she also interacts with your clinicians at the Lake Clinic and Warren Mountain, and there's a coordination function there that happens there. And Charlie, just for the EOCCO board, Health Integrated is due to come and make a presentation sometime real soon.
Right, so on Wednesday, we have the advisory panel, so we'll be kind of.
Okay, I'll be at that.
You'll be at that,
Yeah.
and then we're trying to set up, I think we've been trying to set one up for, a few months now, is to do the quarterly meeting. What they don't, the ROI is focused on once we've had a full year with
What's an ROI for those that don't know?
return on investment. So just to see what the data and everything is and what our successes have been in that sense. And then we also have, we can give you quite a few examples as to what has, these individuals, what has been their successes, how much have we been able to decrease the usage of the ER or whatever it might be.
Health Integrated has been doing this as a company all over the country. And that return on investment that she spoke of, it's a risk-based contract that the EOCCO has with Health Integrated. If they don't perform and save X number of dollars, then they get paid way less. So they said, we can do this work, we're gonna save you X amount of money, and that's why the board keeps asking, how's Health Integrated doing?
Yeah. So Health Integrated.
But we need more data. You guys haven't had enough time getting going to, yeah.
We have a year to get that data so we can actually see, because our program is really, we work with a member for as long as a year to really follow them through and get them where they need to be as far as, and then I'm based out of LaGrange or Union, but our company is actually out of Florida. So our clinicians are either in Florida or they're in Seattle. And the other part is that our clinicians are either counselors, social workers, master's level counselors, social workers, or when we're talking about the medical side, we do have RNs with psychiatric background. We also have an oversight, which is either behavioral or medical physicians that are covering and oversight for those clinicians. So.
Just as since I have the opportunity to have the last word, I'm going to take it. We all had, know about the community health work program. We have one at the senior center. We have a couple here at the hospital. We talk about a success story in Lake County and the return on investment. I'll tell you a story of somebody within, it was a woman in Lake County who had several prior children. And each one of those deliveries was a high-risk delivery. And that patient, this woman, had every one of her prior 3 children, I think it was 3 out of the younger, each one of the prior children had gone to a high-risk center. And when that occurs, whether it's in Medford or in Bend, it can easily cost $200,000, $300,000, $400,000 for the baby to be born and then have to be in the ICU and to survive. Our counselor in Lake County was able to work with that mother while she was pregnant with her next child. And that child was delivered normal in the hospital. It was not considered high risk. And that probably saved the business here, the cost for care, somewhere in the ballpark of $350,000. So that's why when we think about just one person can have such an impact on the cost for everybody, how important these programs are. Tara, we really appreciate what you're doing to be here. Do we have any other questions or issues we want to bring up? If not, I think we're just a few 5 minutes late. Thank you very much for everyone being here. We're adjourned. The next
The
meeting.
next meeting is June 9th at 3 o'clock, and I will send you out.